Okay, hello everyone. Welcome to our presentation with Dr. Julie Nantel, who will be presenting on freezing of gait and postural instability. Dr. Julie Nantel has a PhD in physical activity sciences from the University of Montreal and is an assistant professor at the School of Human Kinetics, Faculty of Health Sciences at University of Ottawa. If you have any questions during the presentation, please type them up in the text box that should be on the right-hand side of your screen, and Dr. Nantel will try to get to as many as possible. With that said, I will now transfer to you, Dr. Nantel.
Thank you. Can you hear me?
Yes, I can.
Take it. Okay, perfect. Excellent. Well, thank you so much, and thanks everyone for being here. And I'm really happy to present my work today. But before we start, I'd like to introduce some of my my teams. So on your left side, you see my current team here at the University of Ottawa. So you have my students. So my students have been involved and are still involved in the some of the data, some of the work I'm going to be presenting in the third part of the talk. And I'm also going to be presenting some of my work I did when I was at Stanford University during my postdoctoral fellowship. So researchers have been studying balance and balance-related deficits in Parkinson's disease for decades. But still today, PIGD, which is postural imbalance and gait disorders, are probably still amongst the most studied motor deficits in Parkinson. But why? Why is it so important to study freezing of gait and balance deficits? Well, PIGD, so postural imbalance and gait disorders, are related to falls, which touch up to 80% of people with Parkinson's disease in the later stages. Fear of falling is also another major concern in Parkinson, as you know, and both of them, so both disease severity and fear of falling have a huge impact on quality of life, of course. So if you take disease severity, fear of falling, and history of falling, so we know now they've been identified as main predictor of future fall. So knowing that you already fallen before, you are at higher risk of falling later, later during your life. As you can see on the right, so when people have this fear of falling and already had falls during the previous time, these people are most likely going to decrease their physical activity, which in terms leads to some balance deficits, which obviously increase the risk for falls. So here's a non-exhaustive list of factors associated with falls in Parkinson's disease. However, even if most of them are highly important to address both in a research setup and in the clinic, my talk today will focus on freezing of gait, the effect of medication, cognitive impairment, and physical activity. And so what I'll try to do today is read to explain the link between these four items and risk of falling. So during my talk, I will address three main questions. So what's the current knowledge in PIGD, so in postural imbalance and gait disorders? So what do we know? Is there a way to slow down the progression of deficits in gait and balance? And if so, is there an incidence of prevalence of falls? So can we do something to prevent falls? And finally, I'm going to look a little bit more in what we're doing right now to better understand PIGD. So I will be presenting some of my work, as well as some ongoing work I'm doing currently. So balance, gait, and mobility are words that we commonly use. However, in a research perspective, these words have specific meanings. And as I always tell my students, we really need to define these terms to have a common ground. So when I'm talking about balance, gait, and functional mobility, you'll know exactly what I'm talking about. So balance refers to the control of your body center of mass. So during all our activities, so standing, getting out of a chair, turning, and also we have to add that. So balance also refers to recovering your equilibrium when you have an external perturbation. So if you're standing on the street, for example, or in a shopping center, and suddenly someone runs into you, then you have to recover that balance. Gait is also means controlling your center of mass. But in addition to that, you also have to coordinate your legs and your arms. So when we are talking about coordination of legs and arms, it's really the rhythmicity of these legs and arms. So think about the coordination between the left and the right leg, the left and the right arm, as well as a combination of the arms and legs themselves. Finally, functional mobility is really the ability to move in your environment and interact with society. So doing your normal activities and being able to enjoy doing them. So of course, the three of them, balance, gait, and functional mobility, are highly related to quality of life. So now, how do we assess postural stability and gait? There's obviously different ways to measure balance and gait, and the tools and equipment you use always depend on your goal. So what is it you want to measure, as well as your setup. So is it a clinical setup? Do you want to have a global measure of mobility and gait, or do you want to have really specific measures, like for some details of your balance and gait? So what you have on your right is a picture of my lab. So you can see two force platforms on the ground. So these two squares you see on the ground, as well as 8 really precise cameras. And the combination of the cameras and the force platform really allow us to really precisely measure balance and locomotion without missing anything about it. So using that equipment you saw on the previous slide, so what we do when you come to the lab is we are often looking at your postural sway. So we're asking you to stand on the force platform, and we're looking at at all the pressures under your feet. And these pressures give us really a good measure of your postural balance and postural instability, if it's the case. So if you look at at the 4 squares you have on the right, so the little lines you see there is actually someone standing on a force platform, and it's really the displacement of the center of pressures under the feet that we see in that figure. So what we did at the lab for one of our study was to compare healthy elderly with people with Parkinson's disease. And so if you look at the control, so the first square on your left, so you see that there's a displacement, because whenever we're standing, we're never totally still. So even if you cannot see it with your eyes, on the force platform, we can see every little movement you're making. So what you see there is that there's a displacement. So that's 30 minutes of signals, 30 seconds, sorry, of signals. So you see that the person is moving a little bit. If you look now on your right, you have there, we divided our people with Parkinson in 3 different groups based on a previous dynamic task. So we divided them in non-fallers, fallers who failed once during the dynamic task, and fallers who failed 3 times during the dynamic task. So just have a look at the signal of the non-fallers. So even if this person is a non-faller, you can see that the displacement of the center of pressure, so the balance itself, the stability, the signal is quite larger. So if you look at that, even if this person is not falling, so not a faller, the signal, the displacement of the center of pressure is larger than our control elderly. Now, if you look at the fallers, so the one in the bottom, so if you look at those who had 1 fall and those who had 3 falls, you can see that the displacement, both in the ML direction, so in the medial lateral direction, and in the anterior posterior direction, is quite large. And if you compare the person who failed 3 times compared to 1 time, you can see that the displacement is really, really big, and mostly in the medial lateral direction. So this direction is really important when we're assessing balance, because we know that the medial lateral direction, the postural instability in the ML direction is highly related to falls. So in this study, what we also did is we looked at the effect of medication and the deep brain surgery on balance. So as you might know, medication is really good at stopping or reducing the tremor. However, there's a lot of inconsistencies in the literature regarding the effect of medication on balance. So if you look at the graph, so looking at the vertical axis, you have the center of pressure displacement. So how large a displacement is. And on the horizontal axis, you have the disease severity. So we looked at the UPDRS scores. And so what we showed in that study is that postural instability increased with disease severity. So that's what you can see in the graphs. You can see that suddenly going to the right side of the graphs, you see that disease severity is increasing and the displacement is also increasing. So both of them increase at the same time, just showing that postural instability is increasing as well with disease severity. So what we showed as well in that study is that people with Parkinson's disease in the moderate and advanced stages of the disease had a large COP displacement and velocity. So both the displacement and the velocity were higher in people in the later stages of the disease. And we know that that's a higher risk of falling. So the importance of the COP velocity is that just think if you have a large displacement, so if you're moving a lot when you're standing still, so that's one thing. I can do that myself and be still pretty stable. However, if you ask me to do it really fast, so if you ask me to do this large displacement but really, really fast, it's at that point that it starts being a little bit dangerous to get unstable and then maybe fall. So an important point we highlighted in that study as well was that in early PD, so in those who had their diagnosis, either a month to 2.5 years before the study. So in these people who did not complain about any postural instability or postural imbalance or falls, in these people we saw a large medial lateral COP displacement. So basically what it means is that before these people complain of postural postural instability in the clinic, we can see these changes in postural control in the lab. So in that study, we had quite a big sample size. So we had a lot of participants. We had up to 129 participants. So we were able to divide these people in two categories. So the first category is what we call normal balance, and the other one is abnormal balance. So what you have to remember is that whenever we say PD normal balance, it doesn't mean that it's normal for healthy elderly. It's normal for PD, which means that it's still higher than our controls. However, it's a little bit better than the abnormal group. So also, what you have to know is that our participants were coming two days in a row. So the first day they were coming on their normal medication, and we're doing all the testing, and they were coming again off their medication, and we're doing the testing again. So in the PD normal balance, what we saw is that when participants were on their medication, their postural instability increased. So they were more unstable on their medication compared to off their medication. We had the chance to have 28 participants who had DBS surgery. And so we look at the effect of DBS as well in these people. And so what we showed is that in the PD normal balance, those with DBS, so the DBS could reverse the medication-induced instability. So our participants were getting worse on their medication. However, the DBS could reduce this instability back to their off state. However, it did not reverse to normal balance. Now, if you looking at the abnormal balance, the people in that group did not have any positive effect of the DBS or of medication. So in both cases, these people on and off medication and on and off DBS had a really large postural instability. So we suggested that these are really important results because we think that it's really important to be able to discriminate these two types of two populations, so we can really optimize the therapy, so medication or Mutter therapy. So I think it's really important to really understand what your medication is doing to you. So do you feel more unstable or less unstable on your medication, and then talk with your neurologist about that. So now, what's the link between static balance, so when the person is just on the force platform, basically doing nothing, and other dynamic tasks. So just think about it. If you're standing quietly on a force platform and you're already unstable, well, this instability is definitely going to show when you're doing dynamic tasks. So what we see is that people who are unstable during static trials, so during quiet standing, are also unstable whenever doing any kind of dynamic task, such as rising from a chair or walking or turning, etc. So what do we know about the common problem of Gait in PD? So if we look specifically at the walking pattern, so we know that people with Parkinson would take slow steps, or on the other side, fast and short shuffling steps. So it's either or. We often see that stoop posture, so the trunk is slightly bent forward, and you can imagine that this stoop posture brings your center of mass a little bit closer to your toes, which by itself, this posture could make you at higher risk of instability. There's also this asymmetrical leg and arm swing. So there's an asymmetry between what the right and the left leg are doing. There's an asymmetry between what the left and right arm are doing. And there's also the arms and legs are not as well coordinated compared to LT control. Also, what we often see is the difficulty to initiate gait as well as making some turns. So when I started my postdoc at Stanford, the main question was, so what's the difference between freezers and non-freezers? Is there specific characteristic of gait that are different in freezers when we compared it to non-freezers? So we decided to look a little bit more into that. So freezing of gait is something we normally see a little bit later in the progression of the disease, so in the later stages, and it has a tendency to worsen with disease duration. Freezing of gait is really hard to predict. We never know when it's going to happen, and when we ask our participants to tell us if they can see it coming, most of the time they can't until it's really, really close to the freeze, and then they can feel that their feet are suddenly, they feel that the feet are glued to the floor, and they cannot really do exactly what they want to do with their feet, and then suddenly they're totally glued to the floor. So what often happens when you try to measure freezing of gait is that if you're taking a participant from the waiting room and you're walking to the lab, that person can freeze 2, 3, or 4 times, and stop walking and then suddenly start walking without being able to explain what's going on. The second we open the door and the participant comes in the lab, the person is not freezing anymore. So that's why I'm saying it's so hard to predict. We never know when it's going to happen, but it's definitely not happening in the lab. And there's probably just like being aware that of being tested for freezing of gait might just trigger something, and then the person is not freezing. However, what we did to counteract this problem is that we, instead of asking our people to walk to measure freezing of gait, we ask our people to step in place. So what our participants were telling us is that, oh my God, this task is so boring. Do you really want me to do that for 6 minutes? And we're saying, yes, we are boring like that. You have to go through it and try to do your 3 trials of 2 minutes, and you'll see what happens. And people were like, I'm not going to freeze, that's for sure. And of course, what the signal you see in front of you is what we call freezing of gait. So these people froze when they were stepping in place. So if you have a closer look at this graph here, so what you see here, so we divided our people in non-freezers in A, in freezers who froze about once a week, in freezers who froze about once a day, here in C, and in D you have people who freeze whenever walking. So if we go back up to the A here, so someone who never freeze. So what you can see there is that the person is able to step. So the red and blue signal you see is going from 0 to 100, going down to 0, 100, and so on for 2 minutes. So we know that the person is perfectly stepping on the force platform, and we cannot see any arrest of movement at all. So that person is doing the task. So if you look in B, if you look at that person, so you can see that at the beginning of the task, right here, you can see that when we said go to that person took a little bit of time before starting. However, the person was able to start stepping, and they did pretty well for about 10 seconds. And then suddenly without being able to tell us why afterwards, you see that the signal stopped. So the person is not stepping anymore. And then again, they start stepping, and they're able to do it for about 20 seconds. And you can see that then you have 4 episodes of freezing of gait. But between these episodes, the person is able to pick it up and pick the signal again and able to step. If you look in C here, this person again had start hesitation. So you can see that's slightly longer than the person in B. So a start hesitation for about 4 seconds, and then they start stepping pretty well. And you can see after that, after 10 seconds of stepping, the person just froze until the end of the trial. Remember, this person is freezing about once a day, but when on the force platform doing the stepping in place, the person froze for almost 90 seconds. And in D, you can see that the person is not able to do a single step. So there's nothing going down to 0, nothing going down to 100, which means that the person is not stepping. So the person is always the feet on both force platforms, and there's no stepping involved there. So until recently, freezing of gait was defined as an arrest of movement, because when you look at someone freezing in the street, well, the person is not moving anymore. There's no movement. However, when you look at the signal on the force platform, you can see that there is a movement. You can really see that the person is trying. So the person is moving back and forth from actually side to side to try to lift that leg, try to unglue that foot from the floor. And so now what we know is that it's an arrest of movement in term of displacement in space. However, you can see that there's still a motor command coming from the brain, and this command is going down, and that's what you can see here on the signal. You can see that the person is trying to lift, but it's just not, the command is not going through. So freezing is not can also be seen in the upper body. So if you ask someone to tap their fingers, so the index with the thumbs, for example, you can also see freezing of movement, and that's the signal you have there in this graph. So you can see that this signal is really similar to the signal I just showed you for the stepping in place. So you can see the right and left fingers. And as you can see at the beginning, the person is able to do the task. And suddenly the amplitude of the movement is starting to decrease. So it decreases until there's a freezing of movement. And again, without the person being able to tell us why and how they did it, then they're able to pick up the movement again. And you can see beautiful cycles here. So there is new evidence that both the upper freezes and the lower freezes, so the freezes in the ends and the freezes in the legs could be linked. However, we still don't know which of the upper body or lower body occurs first, and we are not sure exactly of the mechanisms behind freezing of movement. So if we don't know the exact mechanisms of freezing of gait and freezing of movement itself, we do know the triggers, the most common triggers of freezing of gait. So one of the main trigger is actually turning. When you ask people with freezing of gait to turn, well, they have a really hard time, and it's harder most of the time when you ask participants if it's harder on the most affected side or on the least affected side. It's often they would tell you that it's harder when you ask them to turn on their most affected side. Gait initiation is also a really common trigger for freezing of gait. So if, for example, you're at a red light, a traffic light, and you are just standing there waiting for your green light, and then suddenly the green light turns, and you often see people, freezers, freeze at that point because they know they have to go, and they have this stress of crossing that street before the light turns again. And that's something we see really often. So both turning and gait initiation. So really recently, there were 4 models of freezing of gait that have been presented. These, maybe some of you were at the 3rd World Congress of Parkinson's disease in Montreal. And so these models, what we have to understand is that even if we have these 4 models that can explain part of freezing of gait, none of them totally explain freezing of gait. And the reason is because there's so many different triggers of freezing of gait and so different tasks that can lead to freezing of gait. So these 4 models, there's 2 motor models, the threshold model and the decoupling model, and there's 2 cognitive models, so the interference model and the cognitive model. So I will explain these models more precisely in a few seconds. So in the threshold model, freezing of gait is explained by the degradation of gait characteristics such as step length, frequency, and regularity. So when you look at the step cycles, so we said that people with Parkinson would have shorter steps, maybe a more faster steps, and also more irregular steps. So this model says that because of these difficulties, these gait deficits, they just reinforce each other up to a certain threshold where the person is not able to control the gait itself, and then there's a breakdown in the motor program, and then the person cannot really do a step, and there's a freezing of gait, a freezing episode. So if you look at the graph here, so in that study, they look at the gait pattern between freezers, non-freezers, and controls. And as you can see, if you look at the freezers in dark gray, you can see that these participants had smaller steps than non-freezers and control, and they had larger spatial and temporal step variation. So they were more irregular than the non-freezers and control. So we know that the frequency and the spatial and temporal variation is really important to explain freezing of gait. So going back to stepping in place, so that's also what we saw in our signal. So which means that it's this asymmetry is not just for gait itself, for locomotion itself. It's also for any kind of cyclical activities. So during the stepping in place, you don't have to move forward; you're staying in place. And when we compared freezers with non-freezers and control, we saw the same asymmetry, large asymmetry in freezers and a large arrhythmicity in freezers compared to both non-freezers and control. And we suggested that this asymmetry and this arrhythmicity was linked to the freezing episodes. So now the cognitive and interference model. So both these models are based on the role of executive function during walking activities. So the executive function is a set of abilities that make it possible to modify our motor program based on our environment. So for example, if I'm walking on the street and my plan is to walk straight down the street, and suddenly there's a kid biking towards me, and I see that that kid is not going to move, so I have to replan my task. So instead of going straight, I now have to move on the side. So executive function is really how flexible you are when you're doing motor activities. So in the cognitive model, so this model says that when the incongruency of the situation is high, and when you have to give an answer really fast, or when there's a cognitive load involved in the motor task, then you're more at risk of having a freezing episode. So for example, if you're a freezer and I'm asking you to walk straight for 100 meters, and I say, never stop, just go, just walk until I say stop at the end of the 100 meters, and suddenly at 50 meters, I put this sign here that you see with all the different items. Well, I'm asking you to do one thing, and suddenly you have this task that you have to replan because you have so many signs. You have to understand what's going on and what you should be doing next. Well, having such an incongruency between what I ask you to do and what you now think that you have to do, and also the cognitive load of looking at all these signs and thinking, well, what am I doing next? Well, that could lead to a freezing episode. If we look at the interference model, so in this model, so it's based on the fact that the deficit in gait would make it a little bit harder to do another task at the same time. For example, if I'm asking you to walk and hold a tray or grocery bags in your hand, well, doing these two motor tasks at the same time might trigger a freezing of gait because both these tasks are competing in terms of motor control. Also, if I'm asking you, if we're walking together and so we just walk like that, and I'm suddenly asking you a lot of questions, and you feel a little bit stressed about that, and you feel that you have to give me a really fast answer. Well, that cognitive task on top of walking could lead to freezing episodes. So it's really important, if you know you have freezing of gait, it's really important to try to reduce dual tasking. Everybody thinks that they're really, really good at dual tasking. When I'm in my office on campus, I have a beautiful view of campus, so I see a lot of people walking. And the other day I was just sitting there, actually not working too hard, and I saw one of my students just walking. He was by himself and was just walking, but suddenly he was texting at the same time. Well, that student hit a pole, so he just ran into that pole there and never saw it. So then I was asking my students in class. Who thinks they're good at dual tasking? And all of them rose their hands. Even that student was not able to text and walk at the same time. Well, in fact, studies show that we're all really bad at dual tasking. We should always do just one task at a time. However, we all think that we're really good at it, and we tend to do a lot of tasks at the same time. However, if you know that you're a freezer, try to reduce the number of tasks you're doing, because you might just induce freezing of gait by multitasking like that. So knowing that the executive function correlates with freezing of gait, we wanted to know if there was other cognitive function that would be involved in freezing of gait. So what we did, We again ask our people to come in the lab and do the stepping in place task because we love that task and it's working really well. So we had the Mutter task, so the stepping in place, and on the other side we had a neuropsychologist doing cognitive assessment, where visual spatial abilities, visual processing, and executive function were tested. So these are the some of the tests. So just 4 of them that I'm presenting today. So what we did is we looked at the stepping in place, so the rhythmicity and the gait variability, and we tried to see if there was any correlation with the results of these tests here. So what we showed is that deficit in visual spatial reasoning and processing was with these 2 tests, so the matrix reasoning and the block design, we were able to differentiate freezers and non-freezers. So our freezers had lower scores compared to the non-freezers. We also showed that the deficits in visual spatial processing was highly correlated with the freezing occurrence and duration. So how many times they froze during the stepping in place task and how long they froze as well. So the score and the occurrence and duration were correlated, as well as the arithmicity and symmetry. So people who had lower scores on the block design had also a higher arithmicity and asymmetry. So we suggested that visual spatial processing when performing a motor task could contribute to freezing of gait. And also that different cognitive deficits, such as the executive function, could contribute to different aspects of freezing of gait. So what we showed is that visual spatial reasoning and processing were linked to the asymmetry and the variability, while others showed that the executive function had a link as well. So I talked a lot about freezing of gait. I talked a lot about falls. But what's the link between freezing of gait and falls? So we know now that freezing of gait is an independent factor for falls. And both falls and freezing of gait increase with disease severity. So you see more falls and more freezing of gait in the later stages of the disease. If we know that there's a link there, we still don't know the exact mechanism connecting both freezing of gait and falls. So the 4th model, so the last model, is given insights about this connection between freezing of gait and falls. So this model states that there's a discrepancy between the intention of moving and the motor responses itself, so when you're actually moving. And this discrepancy would lead to compensation, so motor compensation. So if, for example, you're standing on the force plate and I'm asking you to start walking, and you have this start hesitation we were talking about previously, and you want to start, but you feel that your feet are glued to the floor, then you're going to have these compensation, these movements that are not supposed to be there, but because you're not able to do exactly what you want to do, you'll try another strategy to be able to finally take that step. And that's when people have postural imbalance on top of that, then it's really hard to control that center of mass. And by trying to overcome the freezing and controlling that center of mass, then that could lead to a longer start hesitation, and could possibly also lead to an increased risk of falls or near falls. So we wanted to look a little bit more into the relationship between freezing of gait and postural instability. So what we did is we looked at the effect of medication on freezing of gait, but also the role of postural instability in different components of freezing of gait. So if we look at, to begin with, just the effect of medication. So when you look at, so what you have here is people that we tested off medication, and you have controls, non-freezers and freezers. And what you can see is that for both off medication and on medication, our freezers have larger asymmetry and larger arrhythmicity. However, when you look at the stride duration, so how long they take to do a full cycle, you can see that on medication, there's no difference anymore. So our freezers are not different anymore from the non-freezers and controls. So which means that medication had a positive effect on stride duration. However, it didn't have any effect on asymmetry and arrhythmicity. So that means that the medication can, on one side, have a positive effect on a certain part of the gait characteristics. However, not all of them are getting better with the medication. There's, as I said, no difference in terms of asymmetry and rhythmicity. If we look at balance, so postural control, what you can see here, again, when we compare the controls with non-freezers and freezers, you can see that our freezers have a higher displacement in the ML direction, medial lateral direction, and a higher velocity in both medial lateral and anterior posterior direction. So which means that our freezers add a more unstable balance compared to our non-freezers. Also, we showed a correlation with between postural instability and freezing severity. So how many times you participants froze during the task and how long, as well as a correlation between postural instability and gait asymmetry. So based on these correlations, so we think that as postural instability increases with the disease severity, well, combined with these, combined with the asymmetry of gait and of the cyclical task, if you combine this postural instability and the deficits in the gait characteristics, then it's getting harder and harder to control the center of mass, and then be able to at the same time control the center of mass and control the rhythmicity and the symmetry of walking, and then that could lead to freezing of gait. There's also linking freezing of gait and falls. There's also the possibility that when someone freezes, then the momentum that you have when you're walking, that momentum could put you at risk of falling, because if you have a sudden arrest of movement, well, you might not be able to control this the velocity of your center of mass, and then maybe trip or fall. So now that we know the link between freezing of gait, cognitive impairment, and falls, is there something we can do to slow down the progression of PIGD, so gait disturbances and postural instability? And if so, can we reduce the occurrence of falls as well? Well, I finally have something positive to say, and the answer is yes. So there's definitely a growing interest in exercise in Parkinson's disease, As you can see here on the graph, you can see that the number of studies on physical activity and Parkinson's disease is increasing really, really fast. And for the first time, for those who were at the World Conference and, in Montreal, for the first time, doctors, researchers, and clinicians were agreed that physical activity should be alternative therapy in Parkinson's disease. So there's now evidence in evidence of the positive effect of different kind of physical activities on balance and gait in PD. So we have evidence in Tai Chi, in dancing, and in specific movement therapy as well. So for those who know Michael J. Fox, Michael J. Fox at an early stage, was diagnosed early, and he is big hockey fan. And what he says is that whenever he puts his skates on and jump on the ice, he doesn't feel he has Parkinson anymore, because his movements are getting really fluid, and he really feels that he can do whatever he is asking his body to do, and the body is reacting the right way, and it really feels right. And there's a lot of people having the same feeling whenever they do physical activity. So I said that there's a lot of studies looking at physical activity and the positive effect of physical activity on motor symptoms. However, it's not because there's a lot of studies that they're all good studies. So there's some studies that showed positive results, and some really good studies. However, we need more of those so we can really conclude for different kind of sports as well. So what I hear often when I'm talking with my participants is, well, I'd like to start doing more physical activity, but I'm really scared I could fall either during the practice or after the practice, because I would be maybe more tired because of the physical activity. So how can we be sure that physical activity is not interfering with postural balance? So people are scared that maybe they're going to be more unstable after physical activity. So we actually tested that. So we looked at the acute effect, so the effect right after a practice of an adapted racquetball training on balance and locomotion in Parkinson. So that's a pilot project. So it was we did it with only 9 participants. So the idea was really to look at the effect of the practice after. So we tested the participants right before the practice and right after 45 minutes of moderate physical activity. So we looked at the motor function. So we asked people to walk. We asked people to do some reaching task. We look at, obviously, postural stability and postural control. And we also tested for mild cognitive impairment. So we did 4 different motor tasks, but the task I'm going to present today is called a functional reach. So it's a dynamic task where you are standing on a force platform. You're standing still for about 5-10 seconds, and then at a go signal, you just move forward and try to reach as far as you can without lifting your heels. And then another go signal, you come back and stand still for about, again, 5 to 10 seconds. And so what we did is we looked at this specific task before and after the practice. And we also look at the range of motion at this task, and the more specifically at the postural stability as well. So again, the center of pressure. So we also looked at the range of motion of the arm on both sides. And so what we saw is that after practice, the movement time was shorter. So people were able to, when we're looking at a gait task, they were able to move faster. During the functional reach, the trunk range of motion was higher, so people were able to go a little bit further forward. And sorry, and bradykinesia was also slightly decreased. So overall, people, when we're asking how do you feel after your practice, they were feeling better. They were feeling a bit more fluid in their movement and faster as well. So looking here at the functional reach itself, so in terms of what we saw on the force platform. So I'm going to compare before the reach, so when people are just standing on the force platform, during the reach, and after the reach. So if you look here in blue at the signal, the COP displacement when they before they reached, you can see that there's some movement there. But when you compare to the reach itself, you can see that during the reach, when the person is really far forward, so bent forward, you can see that the displacement is really, really large. And that's really normal because the person is trying to keep their balance even if they're pushing themselves as far forward as they can. However, the interesting part here is looking at the difference before and after the reach itself. So when you look after, look how big the displacement is now. Compared to before, it's almost twice the size as before. So what that means is that people after the reach, when they come back and they just stand still for 5 to 10 seconds, well, they're really unstable. So during that time, if, for example, someone was walking by and just pushing these people would have more, most likely to take a step to be able to keep their balance. So we did not see any differences. So we did not see any differences in terms of balance before and after the training. So we did not see any negative impact of the training itself of 45 minutes of racquetball. So there was no difference before or after. However, what we saw is that freezing of gait was related to postural instability after the training. So when we correlated freezing of gait, the results of the questionnaire, and postural instability after the training, we saw that there was a correlation. So those with freezing of gait were more unstable than those without freezing of gait. So when we look at the results of our cognitive questionnaire, so then people with a lower score on the questionnaire, so people with potentially mild cognitive impairment, were more unstable both before and after the training. So what we can see here is that freezing of gait has an impact. If you're a little bit tired and you have freezing of gait, you might want to be a little bit more careful after practice. If you have mild cognitive impairment, well, mild cognitive impairment seems to have a global effect on your balance. So before and after, these people were more unstable. So what we see here, there's so many benefits of doing physical activity for people with Parkinson's disease that this should be encouraged in a daily basis. So people should be encouraged to do physical activity. However, if in the morning you go to the gym or you go to your dance class and you have a really good training there and you feel that you really moved a lot and you feel good about it, then there's no reason to do really hard activities during the day. So if you have your physical activity in the morning, try to avoid doing some hard physical activities during the rest of your day. So just try to rest. Doing like normal activities. Try not to go on your roof and shovel your roof, shovel the snow on your roof, for example. And more so if you know that you have a problem with your attention or memory, or you feel a little bit off that day. So now a little bit about our current study. I'm actually really interested in looking a little bit more into this mild cognitive impairment and the role it has in freezing of gait, as well as the role of postural instability in freezing of gait, and try to better understand the mechanisms involved in these deficits. So what we want to look at more specifically is there a difference between fallers and freezers? Are these people falling for the same reason? Or are freezers falling for different reasons? Or is it that the freezing episodes themselves trigger this postural instability and higher risk of falls? So can we better understand the mechanisms leading to falls in faller and to falls in freezers? Is there a difference? So this study is possible because of a grant from the Parkinson Society Canada, and it's in collaboration with Ottawa Hospital with Dr. Grimes. We are currently testing, so I was testing just before the presentation. We already tested 20 participants, which is really, really good, and we're looking for 40 more people. So we are looking to compare freezers, non-freezers, fallers, non-fallers, and try to better understand if these people are different and if they're falling for different reasons. So thank you so much for joining us today, and thank you for your attention as well. So now if you have any question, I'll be more than happy to answer. Mm-hmm.
Okay, great. Thank you, Dr. Nantel. So
I don't think there's a really good answer to that. Some people develop tricks.
How do I stop
So for example, for freezing of gait, I know some people, when they freeze, they need to maybe use a visual cue. So some people have a cane with a laser and just push the laser, and this laser puts a mark on the floor, and then they're able to take a step, just to step over that line. Some people would just take deep breaths and just start being able to start walking again. Sometimes people tell me that to avoid freezing, not to overcome a freeze, but to avoid freezing, when they're walking, they would just count. So military style, if you will. So by just counting or singing a song with a specific rhythm, then that would help us to just avoid freezing. But it's really difficult because I was saying that some people need visual cues to overcome a freeze, or some people need a auditory cue. However, some people also say that when they have visual cues, that could trigger for them a freezing episode. So it's really hard. Some people might freeze for 1 or 2 seconds, and other people freeze for up to 30 seconds. And if you remember on the graphic, some people froze for 2 minutes during our tasks. So it's really hard, but I think it's just being under pressure is really a major trigger. So if you can just make sure that you try to avoid a situation where there's a lot of time pressure, that's definitely helpful. Is it like a specific? Is there specific exercises or?
Okay. And Betty has a question.
Okay,
Any
well,
exercises to help?
Okay, so so as I said, there's now evidence that some type of physical activity have beneficial effects. So what we know is, for example, tango dancing is can be beneficial for people with Parkinson. And even more beneficial for the person who's leading, because then you have to initiate movement and you have to stop movement and you have to also direct someone else. So there's a lot of there's a motor component of it, but also a cognitive component. So you're really working both the cognition and the motor pattern as well. There's studies looking at Tai Chi has a positive effect on Parkinson. Then again, during Tai Chi, you really have to control your movement and control your balance. It's really the interaction between the slow movement and balance. And some studies showed good results there. But as I said, so in our study on racquetball, so people could feel that they were feeling better after the practice. So what I always tell people when I have this question is it's not really the type of exercise you're going to do. It's really try to do something you like. If you hate dancing, don't go to a dance class. You're not going to pursue that class. If you like, for example, if you like racquetball, well, try to join a group of racquetball. If you like biking, try to bike a little bit more. In biking there's this cyclical movement as well with the pedals. And if you're a bit afraid of falling, I had two participants this week saying that they used to love biking but they stopped because they fell. Well, then you could also do indoor biking, so stationary biking. So there's not we need more studies looking at really specific exercises and sports. But for now, I would just say if you're able to go out there and move, that's already a really good start.
Okay. So our next question is
so it's really hard to say without knowing the type of medication and the dosage. So I would say it's really, really important that to have a good connection with the neurologist and making sure that whenever you have a visit to the neurologist to put down questions you have for them, because once they're sometimes once we're in the office with the neurologist, sorry, sometimes it's there's a lot to do and understand, and just put down your question, put down some remarks like that, and make sure that you ask the question, because could be the medication, could be the disease itself, just becoming more severe. But yeah, just I encourage you to ask and talk with your neurologist. I didn't get the second part of the question.
All right. And Shashi wants to know, I have been diagnosed with Parkinson's, but I'm very tired in the morning. Always feel very lethargic in the morning. Any suggestions?
So if it's in terms of physical activity, I would say really go with your rhythm. If you feel that you in the morning it's really hard for you to move, it's really hard to start doing your chores or doing any kind of activity, try to start slowly in terms of if you know that you're in that state in the morning where nothing is happening, obviously don't put yourself at risk of falls by doing some difficult chores or tasks. I would just try to maybe start moving slowly and trying some flexibility exercises. So just stretching a little bit and maybe start moving slowly, and maybe by sitting in a chair and just moving the legs and the arms slowly and possibly stretching. And then maybe if the idea is to do physical activity during the day, maybe don't choose the morning, but choose part of the day where you feel that you're a little bit more in control. But always try to, even if you feel lethargic, try to move a little bit and try to push yourself, but without putting yourself at risk. Again, I would suggest talking to your neurologist.
Okay.
It's really hard to.
Wants to know,
it's really hard to answer a question like that
are there any
without knowing exactly the profile. However, again, in terms of physical activity, people with dyskinesia told us that during the practice they could feel that this dyskinesia was reducing in amplitude. So they were feeling that they were more in control of their movement in the middle and late part of the activity.
Okay. Jerry wants to
for
know,
cramps during freezing, I never had anyone complaining about that.
Any correlation between both? Any remedy?
That would make sense if there's a contraction of the muscles during the freezing. That would make sense that at some point cramps could appear as well. However, cramps are part of Parkinson's disease, so I would look in a little bit into medication at that point, and again talk to your neurologist to know a little bit more about the side effect of certain medication on that type of physical issues. But if I may, I would just say I was just going to say stretching is really important. So I would really suggest to incorporate stretching on a daily basis for people with Parkinson's disease, just to make sure that to try to work a bit on that rigidity you might have in your joint and muscles.
All right.
I'm not sure I understood the question. So using a walker, is that right?
If the use of a rollator walker with Parkinson's can have a positive effect of reducing the chance of freezing of gait.
I have to confess that I'm not a big fan of walkers. Yeah, just because so if you look at people with a walker, you always see that the person is even more stoop than just standing without the walker. So the walker itself would sometimes put you in that position where your center of mass is a little bit towards your toes, and then I would, if you need it, obviously take your walker. But if you don't need it, then just try to walk normally, or with maybe with poles or a cane. But I'm not sure if a walker would reduce the occurrence of freezing, because the freezing is really the feet are glued there, and you don't want the walker to go forward without being able to take that next step. So really the only thing when you're freezing is really to have any kind of trick that could make you overcome that freeze.
All right. Teresa wants to know.
So I think the physical activity, one thing I didn't say about the results of the racquetball study is that when we looked at the range of motion of the left and right arm, we saw that even if people were playing, for example, with the right arm, so holding the racket with the right arm, we saw an increase in range of motion, so in amplitude of motion in the other side as well. So what we saw is that physical activity in so the racquetball was not just good for the dominant side, so the side holding the racket, but for the other side as well. So it looks like physical activity has this global effect on the body, and it's just doing this, making your body move and making sure that you have a complete exercise, meaning that you're using your arms and moving your legs and moving your torso. Then you have better chances of having this overall and global effect of physical activity. So, like any other training, if you're training, if I'm asking you, for example, to stand on the force platform, and I'm suddenly moving the force platform either forward or backward on the sides, of course, at the beginning, you're going to have to take a step. And if I'm moving the force platform too fast or like just too much, you might fall. But by training, by practicing this specific activity, you might be able, after a few trials or after a few hours, you might be able to stand on that force plate. And even if I tilt it really fast, you might be able to stand on the force plate and without falling or without taking a step. And by doing so, by doing that training, then you might be able to, your balance might be better when you're doing other kinds of activities where the floor would move or where your center of mass would be pushed forward or side to side. So it's really, when you're again going back to physical activity, if you're doing, for example, Tai Chi, and you practice yourself at really controlling your center of mass when you're doing really large movements, well, when you're walking or when you're doing other dynamic tasks, well, this practice you have during a specific activity like Tai Chi is going to show in other dynamic activities, because now you're able to control that center of mass and control your movement. So that's that's why we think that physical activity is so important. Moving is so important because by moving, doing a specific sports or specific activity, then you're able to transfer this new knowledge in other tasks. I'm not sure about what kind of comments.
Thank you so much for answering so many of them already. Marianne wants to know if you can comment on PSP at all.
Yeah, I can. So PSP is different. The motor symptoms are slightly different from those of Parkinson. We know in PSP that postural instability is a really important component of of the deficit. So I never looked at the effect of a specific training on PSP per se. However, because people with PSP would tend to have a lot of falls backwards, and it's really different than the falls we see in Parkinson's disease. Then it just in terms of the effect of the physical activity itself, how it could affect balance in people with PSP. I'm not sure I can answer that question. However, I would say because prevalence of falls are really important in people with PSP, I would say try to always start really slowly. If you want to do some exercises, I would say start doing an activity that you can do sitting if you want to, and then just start from there. And again, if you're able to do some stretching at the beginning, that's really important. So I would definitely recommend stretching.
Okay, and the last question we're taking for today. Great question. So
shuffling is definitely a problem in terms of if you're shuffling, it means that your center of mass is always in front of your feet. So your center of mass is always moving you forwards. And you're taking these really small steps and these fast steps, and they're getting smaller and faster when you're moving. And so most of the time people have to either hold on something to regain balance, or we try to stop the fascination itself. However, by stopping the fascination, what we see sometimes is that because the center of mass is in front of the base of support, so in front of the toes, then the person has to sometimes have to overcome a fall. So it's really hard. It's really hard to know how to regain your balance when you're in a position that you're really unstable. So I would say try as much as you can to think big in terms of your steps. So if you know that you have a tendency to have fascination, then whenever you're walking, try to give yourself a rhythm, and a rhythm that would allow you to make longer steps. If you're able to keep these steps longer than what you would normally do, then you might reduce the risk of having a fascination episode. But just really, it's all about thinking large and big, and making sure that you exaggerate your movement.
Okay. So thank you so much for that, Dr. Nantel. It was a very insightful presentation, and thank you so much for answering all those great questions. I hope
Thank
that you
you,
all found
and
it helpful
thank you
and
everyone
informative. A
for
recording of the
being with us
webinar will be
today.
available in 5 to 7 business days on our website. Thank you for attending, and have a wonderful day.